Welcome to a webinar on procedural ultrasound. My name is Arun Nagdev. Again, welcome to the webinar on procedural guidance in emergency medicine with ultrasound. My name is Arun Nagdev. So procedural guidance with ultrasound has been something I've been spending a lot of time working on in the last 10 years. I think this came from my desire to improve my success rate and reduce error. As you can see from this patient, this is a classic patient we have to put central lines in. This is not what's in a textbook. Getting access quickly, being comfortable getting a line in this patient can be challenging sometimes, and the difficult part is not everybody looks like that. This is a patient that I had that needed to get his shoulder aspirated at about 3 in the morning. No other consultation. If you look on the left, I'm aspirating a large amount of hematoma or hemarthrosis from this patient's joint. On the right, the ultrasound image, you can see the needle quickly coming in to that space and obtaining joint fluid, or actually hemarthrosis in this case. The beauty of this procedure is, one, I'm confident where I'm going. Two, I know exactly what I'm looking at. And three, I know that there's actually fluid to aspirate. So all these things actually make this procedure much easier for me. And I think spending time understanding what effusions look like on ultrasound really actually allow you to guide your therapy and decide when to have a patient. This is a patient that I had that came in with hypotension and difficulty breathing. He actually had a uremic pericarditis, and you can see from this short clip, he's having signs of tamponade. He has a couple signs I'm not going to get in detail with, but clearly had clinical signs of tamponade, and actually his right ventricular free wall is collapsing in diastole. This is his right ventricle. You can see that kind of scalloping. The beauty of this is, again, I made the diagnosis fairly quickly at the bedside with a quick ultrasound evaluation. And second, using just some basic techniques, which is in-plane evaluation or in-plane visualization, of the needle tip, I was able to guide my needle directly into that space, slide a wire in, and pull out the fusion. So I think what this all comes down to is, as an emergency physician, and I think as most physicians, really the last thing we want is a ton of stress in our life, and we want really to make this job enjoyable. And I can tell you the times that I'm probably the happiest clinically is when I'm comfortable with what I'm doing. I know what I'm doing. I have a clear pathway, and I feel comfortable helping patients. It's stressful to do procedures you're not comfortable with, doing these blind, and missing and having the patient either having a bad event or you feeling bad about your care. This is classic job satisfaction skills. And you look at physicians when they are excited about what they do, it's when they're comfortable with the patients. We're all comfortable taking care of certain things we're good at. And when we're not, it gets really stressful. And I think this is the core of job satisfaction. I think this really also comes down to what EM is all about. Emergency medicine is all about being comfortable in your chaotic environment. And if I can make your life less chaotic and more enjoyable, I think I've done my job. And I think this understanding procedural guidance and being good at it really makes emergency medicine a really fun job. So let's start with kind of something basic that we've all talked about in the past, ultrasound-guided central venous cannulation. Even though it's all in the literature, we talk about it constantly, I still think there's some room for improvement. And a simplified method to do this can really make your life much easier. Classically, we talk about blind technique or landmark-based technique, and these have certain things that none of us want, and that's error. And the error that we talk about most commonly is arterial puncture. And if you look, about anywhere from 1 to 10% of patients with blind landmark-based techniques have arterial puncture. This is a New England Journal 2003 study. Classically, we see the patient on the right. This is one of my residents who's thin and healthy. You see the sternocleidomastoid and the clavicle, and we classically aim at the ipsilateral nipple if we're going in between the two heads of the sternocleidomastoid. This is a great technique. I've done the blind procedure when I was a resident, or the landmark procedure is when I was a resident. The problem is that our patients don't look like that. They look like this. And the problem is you can't palpate the clavicle. You can't feel the sternocleidomastoid. There's really little room for that palpable anatomy. And what's great is ultrasound gives you that anatomy. It allows you to overcome the intrinsic flaw of adipose, the intrinsic flaw of abnormal anatomy, and gives you a clear view every time because you have this amazing tool in your hand. So again, in this patient, even though I can't see anything, I can pretend I can because I can visualize her IJ or carotid. So let's talk about the literature really quickly because I think this is it's somewhat irrelevant when it comes to procedural guidance. I can show you that in emergency medicine, in critical care medicine, and in pediatrics, in the hands of very experienced providers, their success rate is minimum. Their success rate is actually very high, and their adverse event rate or complication rate is very low. The hard part is how to extrapolate that data to you or to somebody who is more novice in this field. And so I think that when you look at some of the problems that we have is we tell people, well, ultrasound guidance for central venous cannulation, you have a very low rate of arterial puncture. And we see, and this is a nice study done by Dr. Blavis, that when we watch our residents do this who are less experienced, they actually have problems. And this is a nice ultrasound evaluation where they visualized the residents doing ultrasound guidance on task trainers and show that they actually puncture the wall 64% of the time. So if you look at this picture here, if the IJ is very loud to the carotid, you're fine. You'll go through the IJ and nothing will happen. But if the IJ sits right on top of the carotid, this is where it classically punctures into the carotid, and you can actually have major events such as carotid puncture and AV fistula. So I think that this is where the problem begins, is we expect everybody just by reading literature to be comfortable with this. So let's talk about a step-by-step procedure, something that can make your life much easier. And I always say that use two things. One is your skill level, and you have to be honest with your skill level. You're a beginner, you've done one or two of these, and the ultrasound anatomy that you're seeing. So classically, if you're a beginner and the ultrasound anatomy is clear, use the out-of-plane technique for the right or left internal jugular. And I always tell people to scan both sides. Or the femoral. If you're really new at this and you feel really uncomfortable in the neck, I think the femoral is a fine place to start. Short-term use of the femoral can be really useful. Ultrasound guidance can help you in this as well. Once you get a little more advanced or become an intermediate, so you've done more of these, and now you have more of a chance to kind of think outside the box, you can try the oblique technique or the long axis technique, and I'll talk about both of these. And once you're advanced, you can try the subclavian. I think this is really meant for advanced providers. I've seen errors with this, and even though literature states it's very low rates of error, I have seen errors with this. So I want you to be comfortable first before you move to that technique. Do some basic ultrasound evaluation. You can see this picture, the provider's resting his hand on the patient's clavicle, called clavicular support. Gentle pressure, gel, with the probe marker facing to the left. You can see it correlates with the dot on top. And you can see here, it's correlating with the ultrasound image. And you can see I always start with, if you're a beginner, find your thyroid. You know it's medial, you know where you are. Then you know your carotid, and then you know your IJ. And the beauty of doing that is you have a really simplified way of not getting stuff confused. If you move the probe to the left, the screen, everything should move more medial. So this is nice to get a basic understanding of where you are. And again, let's do that one more time. So let's start with the thyroid, and then the carotid, and then the IJ. So again, this is the right internal jugular. You're looking down the patient, and you have a clear view. You can see the sternocleidomastoid right on top. So step one, look before you leap. I always say this. So the idea being you want to scan both sides of the neck because God forbid there's something in the neck before you start that you can't cannulate. So there's no reason to prep one side, start, and realize, wow, I have a big abnormality here and I can't use this side. I need to go to the other side. So I think it's just easier to look. So this is an example of a sepsis and a sore throat that actually was transferred to my receiving center and was sick and needed resuscitation. He had no access. And we actually looked on the right neck. And you'll see on this video, he had a large thrombosis of his IJ, except it's completely clotted. This gentleman had Lemire syndrome, a thrombophlebitis of the internal jugular that spread from the neck. And if I hadn't known, I would have tried and cannulated something that probably wouldn't have been cannulatable, if that's a term. The left neck, very quickly you'll see, is nice and open. Didn't shoot a lot of video because we saw that left neck and then went and cannulated it pretty easily. So again, I think scan both sides of the neck, find the one that's right for you, visualize before you start. This is a great way to just look around. So the classic short axis technique, this is how I was taught. And the way I was taught was to hold a probe, and then as you look at the screen, advance the needle and visualize the needle tip. The problem with that for me is, one, as a novice sonographer, not an advanced sonographer, somebody who's not done this very often, moving the probe, moving the needle, aspirating, and looking at the screen really can cause a lot of confusion and makes it difficult for the novice provider. And I see residents flail at this. And so this is the classic thing you're looking at. This is going to be what your ultrasound screen, this is in a phantom. As you can see how you're kind of moving the probe and you're visualizing the needle tip. This is great. It's a great technique. The problem is, in beginning or novice sonographers, I think they have a really hard time with this. Because of that, I kind of made up this modified short axis technique, which I think is a little bit easier for the novice provider. The idea being is just to use your basic geometry. The idea is, if you visualize the depth of the IJ, if you just come back that same distance and come in at a steep angle, at a 45, 60 degree angle, you will cannulate right there. This allows the novice provider not to move the probe around, set where they're going, and then just aspirate. So it's one less thing. It's like it can kind of, doesn't have a cognitive load. You can reduce that cognitive load by not moving that probe. So let me show you what I mean. Here, the ultrasound system, what's nice about it is it even tells you the depth. So you can see this is the total depth of the screen is 3.8 centimeters, and the depth markers indicate that this IJ is probably anywhere from 1 3/4 and 2 centimeters deep. If that's the case, then you can back the needle up. Commonly, our residents like to go right underneath. And again, if you're very comfortable with your technique and you've done hundreds of these, then you can decide the way it works. But if you're starting to do this, I'd recommend coming back. This is move the needle, have the needle set further back, and don't move that probe. The idea being that you know where the vein is, you want to come in and aspirate, and the aspiration will tell you when you're in the vessel. Another technique is, if the IJ is sitting in this anterior position and you're scanning off plane, so you're not scanning perfectly on it, you'll see that this IJ slides off the screen. That means you're not on the IJ itself. You get the right axis and the IJ will sit right up and down. And now I know the direction of the IJ, the depth of the IJ, and I can come in and puncture perfectly clean. So again, step 3, perpendicular to that probe. And what I mean by that is, when you scan up and down the neck, you know the direction of the IJ, come in the same plane and come in nice and steep. Again, same idea. If the IJ runs in kind of an odd direction, then you come in that same direction, parallel or right on top of it. And here you can see my resident, she's going in, she's aspirating, you can see her pulling back on that plunger, and boom, she gets access. Again, if the patient's got a blood pressure of the 180s and you can clearly see non-pulsatile blood, and it's nice and dark, it's probably in the vein. But again, in the hypotensive, sick, septic patient, when the blood pressure is in the 60s, 70s, and you're trying for central venous cannulation, this can be tricky. So what I was taught was check a chest x-ray or a venous blood gas. Again, not 100% accurate. I think these are incorrect. Central venous pressure is a great test. If you see the central venous pressure at 90, you know you're in the artery. If you see the central venous pressure at 16, you know you're in the vein. The problem is, along with getting access, you have to dilate up that vasculature and then put the catheter in and then do all this. So you're going to be in trouble. I think an easy technique is, you have the ultrasound system right there. You have the probe right in your hand. So visualize that wire. And you can see that wire really quickly proximally. So I want you to, once you put that wire in, to slide proximal, almost hit that clavicle. And you'll see here my resident gets access, and then slides that wire in, and then puts a probe right back. I'd want her to slide all the way down to the clavicle to visualize that wire. This is a transverse view. You can see that kind of artifact that comes down, but that's because of the wire. You gain this nice artifact right here. And in a longitudinal view, you'll see that wire clearly. There's a carotid underneath. Here's your IJ. And the beauty of this is that, for me, it confirms the fact that you're in the internal jugular vein. So case 3, this is something I came on to shift with, and this patient had a central line placed, and they were starting compressors on this patient because of a bacterial pneumonia. And I walked in the room, and luckily my resident on rounds grabbed the ultrasound machine. This was read as by radiology as there was a tube in place for endotracheal intubation, and there was a central line in place, but they couldn't differentiate arterial versus venous. And you can see he puts a probe on the neck, and right away you're seeing this triple lumen. It looks like it's in this vasculature. I can't tell if it's artery or vein. He puts color on this, and he puts some Doppler, and you can clearly see this is an arterial cannulation. Now you have a large 7 French introducer or catheter in this patient's carotid. Here's another example. Again, IJ, and you can see how they've gone through the IJ probably and gone right to the carotid, and there's your triple lumen sitting in your carotid. Again, not ideal for anybody. So now back to our patient. You have this, and I'm on rounds. Do I pull it or leave it? I'll tell you, when I was a resident, I used to pull these all the time whenever we used to, by mistake, cannulate the carotid artery and hold it. This was a classic thing we did in the ICU. I think that really we need to look at what the data says. So single lumen catheters are centers. These are the large 8.5 French, and our triple lumens are 7 French. So the worry is that when you cannulate, when you pull these out, can you have complications? And this is a nice review in a vascular journal that looked at this, and they looked back and they showed that the pull pressure technique had a much higher rate of complications compared to the surgical technique, i.e. Endovascular or open surgical techniques. And some of these complications were not subtle. These were large bleeds. I think somebody lost their airway. These are not great complications, something you would not want in your patient. And I do this lecture all around the country. I've seen this numerous times, and people raise their hands. I've had embolic events from a huge hematoma I caused, et cetera, et cetera. So they recommend if it's a 7 or larger French, you don't want to pull these and get consultation. I can tell you, I work at a small emergency department 2-3 days a month in the Central Valley of California, where there really isn't much consultation. And if I were to cannulate, dilate, and have a single or triple lumen catheter in somebody's carotid artery, to get a vascular surgeon to come in the middle of the night would be really difficult. So I think to make your life easier, before you do that dilatation, before you open up that vessel, find that wire, and then dilate. So this way you prevent it. If you pull that wire out, it's not a big deal. That wire is nice and thin. You can pull that out and put pressure, not a big deal. But once you dilate, then you really got to be careful about where you're placing this catheter. So summary: 1, look before you leap, scan both sides of the neck. 2, use geometry. Basic idea, use your Pythagorean theorem. Find the depth, step back. Always scan up and down the neck and find the direction of the vein. You can do this both the femoral and the internal jugular. And really find that wire before you dilate, especially in patients that you're unsure of. So again, this is your first patient after a lecture, so you're like, this guy is killing me, right? I've come to this first patient, and I can't even see this patient's IJ. The carotid's there. I think I see a thyroid in the medial aspect. Wow, I'm not going to be able to get that. I don't know what to do. So again, I think come back to our algorithm. So if you're a beginning sonographer and there's a ton of overlap or it was completely collapsed, I think there's nothing wrong with going right to the femoral vessel. I think it's a good access point for temporary use. You're not leaving it in there for weeks. You're using it temporarily till you resuscitate and until they go up to the ICU. So again, for the femoral, I think the same idea. You're going to, again, put the ultrasound transducer in the inguinal ligament, probe marker facing laterally, kind of facing toward the umbilicus. And you can see here, you're going to visualize on the right, the femoral artery bifurcates first, and there's the femoral vein. And for all those people that have ever cannulated a femoral vein blind, which I've done numerous times when I was a resident and couldn't slide the wire in, I think you're puncturing that little vessel up top. That's the saphenous. And what's interesting about it is once you puncture the saphenous and slide your wire in, you hit the valve where the saphenous joins the femoral vein. And that's why those would never go in. You get flashback, couldn't thread the wire. Flashback, couldn't get the wire. So here you can see you have a great femoral vessel. You're aiming up towards the umbilicus. And again, artery and vein aiming toward the umbilicus. And again, the same idea. You can do that same technique. Measure the distance down, measure the distance back, the same amount, and come in a steep angle and puncture the femoral vessel. I think this works the same way as the internal jugular vein. Great, so now I send you off on your way, and you've done 15 of these and you're feeling comfortable. You've done a few IJs, you've done a few femoral vessels, and this guy comes in. He's a septic injection drug user who comes in, needs access. He's got no other points of access. And you can see that IJ is right above that carotid. And you can see how if you would go through that IJ, it'd be very easy to puncture that carotid. So what are some of the options you have here? I think, again, a femoral is reasonable, but if you want to be a little more interesting, you can try some other techniques. If you look, these are the patients where you get arterial cannulation, the ones that are performed in short axis, hypotensive, where the IJ is right above the carotid. And you can see this is where this problem happens. So here's a patient we had. You can see here is the carotid artery. This is your internal jugular vein. This is transverse view at the level of the thyroid. And you can see, what's this? And so this patient had a cannulation performed, and the provider went through this flat IJ and into the carotid and actually formed an AV fistula. You can see this. This is a Doppler box, which is incorrectly placed. It should be more vertical. It should be straight up and down, but that's fine. Still gets a point that this is abnormal, and this is classic for AV fistula. You have this thing called the yin-yang sign of a pseudoaneurysm, but this is clearly just a fistula. So this is not great, right? This is exactly what we don't want. We don't want to have a fistula in the neck in a patient who comes in who just needs central venous cannulation. Again, this is a longitudinal view, and you can see that small neck, but clearly a fistula in between. Again, a major complication that shouldn't have happened. They placed access and they pulled that line out. So again, if you're an intermediate sonographer and you want to do a central venous cannulation, you don't want to use a femoral for some reason, or don't want to use the out-of-plane internal jugular, maybe because there's complete overlap, I think another option is either the oblique or the long axis. And I'm going to show you both of these techniques. I think, again, in the patient that has inaccessible groin, maybe there's feces, maybe it's just soiled, whatever. I think it's another option. So the long axis technique is a great technique. The problem is that you need perfect probe placement. If you slide your probe back and forth, you will miss the IJ. And again, you can see this is the point of view of the provider. You can clearly see that you're coming in this long axis, and on the screen you can see the IJ. You can see here, this is on a phantom, that needle's coming in. Again, visualizing the needle as it comes in. You can see that if you're not comfortable visualizing the needle all the way through, you could be off axis and puncture the carotid or puncture the thyroid. And another technique that I do also like is the oblique view. This is another technique which is nice. This is recently published in Journal of Emergency Medicine 2010, and this is another nice technique for those people who are comfortable with the in-plane visualization of the needle. You can see here, this is classic just transverse visualization of the neck. All you do is rotate it. Again, you're able to visualize both the IJ and carotid, and now you're going to come in plane. You can see the video on the right. This is one of my residents who went ahead and placed the line, then thread the wire through, and saved me these images to prove to me that he was comfortable doing this. I wish he would have done it with me, but he was able to do it. This is the internal jugular vein, this is the carotid artery, and this is your thyroid. You can see this is the wire that's already slid in. What he did was he came in visualizing the needle right here all the way as it comes into the IJ and punctures it. The beauty of this is if he goes through, he won't hit the carotid. If he were to come up from down to top, he may have hit the carotid artery. This is a nice technique, threads the wire, and is done, which is a nice little trick. So this is your 20th patient after the lecture who comes in, who has C-collar in. You now are fancy, you want to get much better at this, you want to get much more experience, and you want to try something a little different. You're an advanced sonographer, you don't want to use the IJ, you don't want to use a femoral, you want to try Subclavian. I think this is feasible. I think you have to be comfortable doing it. The literature, again, like I'm going to tell you, in the hands of expert providers is great. Very, very low complication rates, better than doing this anatomic based or blind. I would recommend not doing in patients with really thick chest or large breast tissue. It can be very difficult. So again, here you can see I'm in the deltopectoral groove in a transverse view, and you can see the axillary artery and axillary vein. This is before it gets to the subclavian. This is your pectoralis muscle. Again, not that much tissue here. It could be much bigger. And the beauty of this is you rotate with the probe marker facing cephalad in the deltoid pectoral groove, and you visualize the vein and longitudinal axis. When you do that, then you come in plane and cannulate the vein. Again, you can see that the common problems with this would be is if you, again, are off a little bit, you can actually puncture the artery. Or if you go too deep, the patient's really volume depleted, you can puncture through it, and underneath at the bottom, you could hit pleura. So I think this is, again, a good technique for an advanced provider. You can also do this along with being infraclavicular. You can do it supraclavicular. So in this is a nice drawing of the subclavian vein as it comes over the clavicle, joins with the internal jugular vein, and forms a brachiocephalic and goes to the heart. You can see here I start just like you do a normal IJ, carotid, and thyroid on the right, and I slide down to the clavicle. When you do that, you'll commonly just see your subclavian artery, not your vein yet. When you're in that position, in that just classic visualized subclavian artery, then you drop your probe and you'll see your subclavian vein. The beauty of this is it's very shallow and it's really easy to cannulate that vein. I've done it before with the 18-gauge angiocath when I had a patient who was very sick and I needed access quickly. You can see you come in again in plane and cannulate the subclavian vein. This probably won't work in somebody who has a very, very thick neck, somebody that maybe has some weird anatomy, but commonly this is a nice, easy access. This is a supraclavicular approach to subclavian vein. So let's switch topics now. Let's move on to the ultrasound-guided pericardiocentesis, which I think is, again, a procedure we don't do very often as emergency physicians, but something that I think all of us really need to have a grasp on, because when this happens, there may not be chance to have somebody else come help you. You're by yourself in a little emergency department, or even at my academic center, our cardiologist won't come in late at night to do this. So you can see here, this is a 4-chamber view of a patient that was early tamponade. The right atrium is collapsing in diastole, and you'll see this worried me, and there's a lot of findings that can tell you, indicate echocardiographically that there's tamponade, but the finding that's most important is if your patient is hypotensive and looking sick to you, and you need to drain that pericardial space. So I think this is real guidance. I can send you to textbooks which give you a 40-step technique, but I don't think any of us memorize that. We don't have textbooks out when we're trying to stick a needle in somebody's heart. I think make this easier. I use a curvilinear probe. I slide up right to where I get a peristernal long view, and have the ultrasound machine on the contralateral side, so I don't have to look around to look for the machine. It's in my plain view of sight. Again, the probe is obviously covered because it's a sterile procedure. If you want to mark beforehand, you can find your mammary arteries, which are very, very medial. Rarely is a problem, but just in case you're worried about this, they're very, very medial. They sit right on the manubrium. Then what I want you to do is to come in plane. Again, you can see the video on the right. This patient had a uremic pericarditis that needed to be drained. He was hypotensive. And the needle's going to come in plane, and you're going to visualize it as it comes into that space. Aspirate as you go in. I commonly will use lidocaine locally into the muscle. I go all the way down close to the rib space, but not into the chest. And then right before I enter with the 18-gauge needle, what I will do is I will give half-dose etomidate. It's a nice medication. It lasts a short time. It theoretically doesn't cause much vascular or hemodynamic changes. So I use 0.15 mg per kg of etomidate, about 7 to 10. I'll push that slowly, and the patient generally has a little more sedation, and then I pop into the chest. And you can see this video, I'm right there with the needle, aspirating. I'm clearly into that space, and I can even visualize the wire going in, just like we did for internal jugular vein. And the beauty of this is it's controlled. I know where I am. I'm not worried. And you can see this gentleman, I was able to drain that pericardial space pretty quickly. And the beauty is his right ventricle opened up. He felt much better, and I was very happy. Here's his His IVC, again, collapsing. Before it was nice and plethoric. Now it's nice and collapsing. So people say, is this too simplified? Is this too easy? Well, we've done about probably 5 or 10 of these, and I can tell you they're really very simple. And I hate saying they're too simplified. This is a patient who came in into our ICU. He was actually a patient that coded in the field, rosked back with his return of spontaneous circulation. In the ED, he had therapeutic hyperthermia, actually was on Coumadin and went to cath lab. He was cath, and they found a stentable lesion, a culprit lesion, placed a stent, and the patient started oozing from that stent and then had tamponade from the fact that he was bleeding into his pericardial space. Nobody wanted to put a needle into this guy's heart, and we really had no other option. So the beauty of that space, I can visualize, I can get into it, which is surprising, but you'll see the needle coming in. I'm a little too deep. I'm touching the heart. I can visualize that. I pull back and slide that wire in. And by doing that, it's a fairly not difficult procedure. Again, visualized, safe, you know what's going on. So let's move on to, I think, something that's even more important to me on a daily practice level is ultrasound-guided joint aspiration. The reason why these are so important is, along with guiding me into the space when I see an effusion, it also tells me in patients that have red swollen joints, no, you don't have an effusion. And I don't need to tap it because I don't see a large effusion in that space. So I'm going to talk about some basic soft tissue ultrasound. And when you look at soft tissue, you can see here, this is an abscess. This is superficial. It comes up right to the top, drains down, purulence right here. Conversely, here's a joint capsule or joint space swelling. You can see bone here. There's nothing right in the skin surface. This is nice and contained because the joint capsule, which is nice and tight, is swollen, and this anechoic area is in the joint, which is the beautiful part of this. You're tapping really the joint capsule. So again, when we look at x-rays, you'll see we're looking at that space. You're seeing edema there, and you're like, oh, they have a joint effusion. So again, you're not putting the needle between the two bones. You're tapping the joint capsule. Again, the two probes we commonly use, a linear for shallow procedures. You can see here, this is the ankle. If we're gonna tap the tibiotalus joint or the ankle joint, the linear probe is ideal because it's so shallow. Decreased depth and increased resolution. Conversely, if you're doing something that's deeper, like a hip, you're gonna use a curvilinear probe. And you can see here, we're gonna use the curvilinear probe to find some basic landmarks. We'll go over the hip because I think it's actually one of the easiest joints to tap. I know it sounds counterintuitive, but I think it's probably one of the easiest. It's almost as easy, I think, as easy as the knee to tap. And again, the curvilinear probe is nice, but you get more depth, but you decrease resolution. So I always talk about landmark-based ultrasound, and what I mean is use basic landmarks with your ultrasound to know where you are. So examine the unaffected extremity. If somebody has a swollen hip or has pain in the hip or pain in the ankle, evaluate the other extremity. Find your basic bony landmarks and know where you are. Look for joint space, joint capsule swelling or effusion, and compare it to the affected extremity. And again, look for that distended joint capsule, because once you see a distended joint capsule full of fluid, A, you can get to it, and B, you know what to do. So here, this is the in-plane technique. We talked about this already. You're going to watch the needle tip all the way down. And this is the out-of-plane technique. And this is how we do central venous cannulation. You're not seeing that needle all the way through. This is a little more complicated, I think. But for certain techniques like the ankle, I think you're kind of forced to do that because you don't have a lot of space to kind of maneuver your needle. So start with the hip, because I think this is something that's pretty simple. So you want to identify classic landmarks. Again, here's your inguinal ligament on the left side, and you can see the probe is placed right in that ligament with the probe marker facing laterally. And you can see here on the bottom right image, you see that femoral neck and you see the femoral vessels on top. This is what you're worried about. When you talk to orthopedic surgeons about what they worry about when they do hip aspirations, they really just want to avoid the femoral vessels. If that's the case, you can see them and you know where you are. So again, you in that position, and then just rotate the probe with the probe marker facing up towards the umbilicus. The beauty of doing that is you get a great view. You have that nice progression of the neck to the head of the femur, and you can see right here, there's the head, there's the neck, and the iliofemoral ligament runs right on top, and in that space is that anterior synovial recess. Generally, there's a little bit of fluid in there. You have to have some fluid in your joint, otherwise you can't really move, and that's normal. The key is compared to the other side, which is affected. So normally you have a little bit of fluid. The other side has a nice large amount of fluid. You can easily get to it. You can see here, this is on the left is the normal hip. There's that head, there's that neck, there's that iliofemoral ligament coming right over. Beautiful view. Compared to this side, this is your head, this is your neck, this is an arthritic, inflamed hip. And you can see right here, this is that iliofemoral ligament. I wouldn't know just from this ultrasound that it's an arthritic hip. All I know is there's an effusion in the joint capsule, and my needle can reach that pretty easily. Let me show you how to do that. Again, always all procedures, these are sterile. You can have a nice sterile sheath, and you have the ultrasound probe on the contralateral side, so you're visualizing it in your plane of view. This is gonna be an in-plane procedure with the curvilinear probe, and you're gonna come right in. You can see almost that needle coming in and going to that small effusion that we tapped one time because we really were worried about a joint infection, excuse me. And you can see here, here's the video, here's the head, here's the neck. They're scanning back and forth. They see a little bit of effusion. And here they come in, there's that needle kind of pushing, popping through that iliofemoral ligament and aspirating. That's it. I kid you not, this is probably one of the easier taps that I do. We stopped doing local. We just spray with some ethyl chloride. You can do a little local, but ethyl chloride works as well, and I think it's less painful for the patient. Let's move on to the ankle, because I think this is another joint that commonly is tough to do with laminar-based techniques because it's hard to figure out all the tendons and ligaments. So I think all you have to really focus on is the medial aspect because that's where there's no vasculature. Once you are able to find the tibialis anterior, the space medial to it between that and the medial malleolus is the space you're going into. So how do you do this? Again, ultrasound, the linear probe, you slide down from the tibia and slide down until you bump into the talus. You get this nice V formation, which is classic. That little area inside is just fat. You can't see much, but there's no effusion. And again, you're going to come sliding down, probe marker facing caudad. Again, on the left, tibia, talus, nothing in that space. On the right, tibia, talus, fluid contained in that space. So therefore, there's a joint effusion, and I can get to it pretty easily with a needle. Again, same thing. You'll see tibia and talus on the left side. On the right side, there's that tibia, there's that talus, and this effusion I can get to. This actually we'll talk about is the tibialis anterior tendon, and once you come medial to that, you're right into the space. It's really that simple. So again, you can see there's a tibialis anterior. If you kind of flex your foot up, you'll actually be able to palpate that in yourself. And if you can't palpate on the patient, you can just find it by just putting the probe on because that tendon has a nice fibular structure. And you see that tibia and that talus. Again, X marks the spot. You're going to come right medial to that. So I actually use the ultrasound to cover the tibialis anterior, and I come just medial to that in an out-of-plane technique with a steep angle in the middle of the probe. And you can see here, there's that perfect example. You see that needle is super steep, and you're coming right in, gently aspirating. As you come down, you might bump into the talus. So again, here's a video representation. You can see maybe I'm seeing that needle tip. I can't tell, but here I probably am, which is okay. It doesn't really matter. I think once you get fluid, that's all that really matters. You know you're in the right space. You know there's an effusion. You know that there's joint capsule swelling. You can tap that joint. And this is one of my residents coming in. I'm holding it for him because he's a little bit more novice, and he comes right in, very steep angle, and aspirates and pulls out fluid. And again, the $1 million question is, can you have septic joint if there's no joint capsule effusion ultrasound? And I can't tell you that for sure. I think it's just very hard to imagine that if you have no effusion that you've detected and you've scanned the space well, that you could have an infection. I can't prove it, but I think that it's pretty unlikely because you can't even get fluid out of it. Again, you have to use clinical sense when you evaluate any joint. So summary, visualization reduces error, and I really do believe this. I think the more time you spend visualizing normal anatomy and then visualizing abnormal anatomy, and you get a path on how to get to that space, either a vasculature or a joint, you really reduce your error. And really, when you learn anatomical variation, it's fascinating to see all this stuff on ultrasound. It's great. You learn that everybody looks really different, and allows the POCUS user to pick up ultrasound and become an expert proceduralist. And I say this without any hubris. I think all of us, the more we get comfortable with ultrasound, we can really become proceduralists that are far beyond what we've expected in the past. And really, this is what makes emergency medicine fun, and make this your passion. I mean, how much more fun is it to be confident that you can do something safely, without error, and give the patient the best care possible? I think it makes my job really, really fun, and I love what I do. Questions? Thank you.